Good morning, everyone. So it's a pleasure to be here with you all today. I'm going to set a little timer to try not to run over. I just want to first start off by saying, and this is, I technically doesn't count as sucking up because she has left, but I want to point out that I think some of you know that I worked in DC for several years before coming down here, most recently as the Assistant Secretary for Management of the U.S. Treasury, which was a role in which I performed the COO and CFO functions for the department. It has been my experience in DC there are two types of people: what people and how people, political wonks or policy wonks and political hacks, people who think about great things to do and people who think about how to get things done. And I think in Dr. McCants Katz, we're very lucky to have someone who is both of those people. And just to hammer this home, I think the things that you are seeing in a creative way to use resources and to spread things around and to move the way she is moving SAMHSA at a rate far faster than I think we've seen done in years past is really inspiring, considering that we really need all the support we can get. So we will just thank her in the ether. For those of you that are following along on my Western tour on Twitter, I spent yesterday in Brevard, North Carolina. I did not go down Sliding Rock, but the reason why we were there is because the department was launching its Western North Carolina Early Childhood Action Plan launch. You may know we launched our Early Childhood Action Plan several weeks ago. We were happy to join Transylvania County, which has been working in their early childhood space for several years, and more recently, as many of you may know, with Sesame Street. And so I got to meet Super Grover, which was the highlight of my day, perhaps my year. But the reason why I start with Sesame Street, because frankly I think everything starts with Sesame Street, but to drive home something that they shared, which is a little bit of an early heads up, is that they're going to be building out their programming around substance use disorder on Sesame Street. They're going to be having a Muppet living in those experiences and talking about the impact to their life, to their families' lives, and how that works. And I just felt like that is probably the best framing that I can start with when we think about what we need to do in North Carolina, which is to be able to think about substance use disorder, as you just heard the Assistant Secretary talk about, in a way that is just commonplace in existence throughout our society, and a chronic disease or disease that impacts so many people's lives and impacts the lives around them, right? So imagine a world in which that is the situation, in which the Muppet's life is real. So what it starts with, if that's our kind of vision call of where we need to go in North Carolina, and I'm preaching to the choir, I realize I preach to the choir a lot, but it's about how do we fight stigma, right? How do we focus on this being a disease? How do we think about the system as it works? And what would that system want to look like or need to look like if we lived in that kind of alternative universe? It would be one in which people had meaningful coverage with regard to SUD, be evidence-based treatments, whole person care regardless of polysubstance. It would think about housing and jobs and other social determinants of health. There would be meaningful prevention. There'd be awareness and key intervention strategies. We'd have systems of support around families. No one would be ostracized. There'd be linkages to care across our system of healthcare and otherwise, from jails, from big institutions, et cetera. We'd have strong coordinated care. Really happy to hear about 42 CFR potentially being reimagined. We'd have good access across communities, regardless of heterogeneous geography, AKA rural. And most importantly, we'd have a well-invested in, well-trained, well-experienced workforce. And that's why we're here today. So I can't thank Sarah enough, the leadership from the Governor's Institute, and all of you for being part of this and really taking time to invest in yourselves to look at this. I know several of you have come for several years, and I appreciate you keeping that energy moving forward. So the opioid epidemic, and I promise I will actually, if you're scared that I'm still on the title slide, hold on. I'll go fast. I think what you probably heard Dr. McCants Katz say, and what I really believe, and I know our team believes, is that the opioid epidemic what it has done is it's shown a bright light on a system under-equipped to deal with substance use disorder, right? And so when we think about what what's happening in the opioid epidemic, when we talk about that at the department, we of course are incredibly focused on the epidemic at hand, but we're really focused in not just making things that are fixed for this, but really reinvesting in our system for the long run so that we never have something like this happen again. This is a team sport. It's going to be a long turn. It's a big ship, blah, blah, blah. I know I'm really good at mixing metaphors. But we have to make those changes to move forward. And so our opioid action plan, for those of you following along again at home, we have a 7-point plan that outlines all of our strategies. And if you look at that again, I hope that you will all later pull it up on the website, North Carolina DHHS Opioid Action Plan. You will see, if you read that through again, think about, wow, they really are just trying to do everything that will apply to substance use disorder broadly and not just opioids, right? And it goes back to that Sesame Street vision that I just kind of outlined. Oh, by the way, I'm pretty sure that the Muppet Sesame Street thing is a little under wraps, so if you could not tweet that, that would be great. So we think about those two big buckets in the context of what we say access and integration, right? And you'll hear, oh no, it's getting ahead of me. The access and integration, and so, and we pushed out that vision February 1st of last year, and we're still marching forward with that. So I hope that you see that we're incredibly coordinated and we're working hard to get all these pieces to fit together. Okay, so now we'll dive into the slides. So I already talked about integration and bias. So we've got 3 big priorities. I'm gonna spend most of my time on the bold, but just real quick so you know, I think unless you have been, well, some of you aren't from North Carolina, right? Who are non-North Carolinians? Right, okay, so you can just enjoy this moment. So the 3 big things. One is how do we integrate and buy health, right? We're drastically changing the way our public health system works. 30% of the people in the state of North Carolina are either in Medicaid or are uninsured. Million people uninsured, million people uninsured, million people uninsured, okay? So 30% of the people are in our direct care, but we also have really strong opinions about how things are going to be done, and we're speaking louder and louder every day so that all of our lovely private payer partners will do the right thing also, right? We want 100% of people to have a different experience in healthcare in this state, and our vision is to buy health, right? Tired of buying health care. Spend a lot of money on health care. I really want to buy health. So we've got a lot of things rolling out there. You've heard about our tailored plan design, probably our standard plan. Big thing there, just remember this November, 20% of the state will roll into, 20% of the Medicaid beneficiaries will roll into standard plans. So the rollout's starting, so be ready. Go to our website, Medicaid Transformation. Okay, number 3, I'm coming back to the bold, healthy opportunities, right? That's our little framing for social determinants of health, right? Everybody deserves the opportunity to be healthy, right? We got $650 million from CMS in our 1115 Innovations Waiver to put what is classically health care money into a lot of other things like housing and transportation and food security that promote health. It's the first of its kind in its nation. People are talking about it. It's incredibly exciting. We're setting up these pilot regions. We're setting up coordinated systems of care. NC Care 360, for those of you that don't know about it, is our coordinated resource platform that will have workflows built in, so you as a provider can say, when you're doing one of our screening questions, you find out someone has a housing insecurity, you can put it in there, and it's not just handing someone a pamphlet, but it's going to one of the community-based organizations in that pilot who will then follow up with that person, and you'll get feedback loops when it's closed, or it'll get punched to another CBO, and they're able to use CMS money to buy the mattress, to pay for rent, to help with transportation. This is transformational, right? It's the coordinated and integrated care that as providers I know you've all wanted and hoped to have, and we're finally going to be able to put some money behind it. And our hope is to prove through these pilots that you put money into things like that and it is far cheaper. I think we all know, I kind of jokingly say that a lot of primary care docs, I realize I'm in a mixed crowd here, but a lot of physical health folks have recently been getting on the social determinants of health train. A lot of behavioral health people have known this for a very long time. Getting people housing and access to these services are incredibly important to stabilizing people into care. Now we need to figure out a way to sustainably fund those things, and that's what we're trying to do with help from CMS. Okay, great, moving along. So today, really focusing on combating the opioid crisis and some of the more systemic things that we're doing there. I have very few slides, don't worry, Sarah. So the first one is, a slide you've probably seen from us for some time. So this is opioid overdose emergency department visits between 10 and 19 year to date, okay? So you can kind of see the upswing. Early preliminary data 2018, looking hopeful, plateauing off a little bit, right? We'll have final data soon, but this is just kind of the tip of the iceberg, if you will, of what we're seeing in the emergency rooms, and we know that there's a lot more kind of under that, below the waterline, but it is a little hopeful to see that swing. The thing that I point out on this slide that's particularly important is that of those people that have come into the emergency department, 46% report to be uninsured or self-pay. Let's say half. So of those people, half are uninsured. Remember my number? What was it? 1 million people uninsured in the state. There's that iceberg. So this kind of backtracks some analysis that the team did. So for every death, we think that there are roughly 4 opioid overdose ED visits for every death. There are roughly 3,854, that's funny to say roughly for that, 3,800 opioid prescriptions dispensed for every death, right? These things are directly connected, this value chain here. It goes back to everything that the Assistant Secretary was talking about, and how do we try to curb this back at every level and divert people from this slipping slide into care. So we talked about our STR and SOR and all those big, fun federal grants. We're incredibly grateful for those in North Carolina. States across the nation are using those resources to transform the way their systems work. We are trying to use some of that money to do that as well, but we have a tough situation in that because we have 1 million people without insurance, the bulk of those resources, roughly 60% or more, are going directly to paying for treatment. Of course, we're very happy to do that. That is the right and most urgent thing that we need to be doing. But what a lot of other states are doing that have far lower uninsured rates, they're able to invest those resources in building linkages of care and changing the way that their system functions and building up provider capacity, et cetera, et cetera, et cetera. So that is a little bit of a tough spot. This looks at, in particular, the STR grant, which was that first 2-year thing. I could not be more proud of my team. Dee Severino really leads the way here in getting those resources out and making sure they're going into the right place at the right time. A lot of states really struggled to get that money spent fast in the first year, and we ended up hitting about 90% of that cash being spent and getting it into care. And so North Carolina led there, and I think that was our effort to be as responsive to what we know how serious the epidemic is in North Carolina. So this graph, which is too small for you to read, I just want you to look at the colors. So do I have a laser? Oh, I have a laser. So the point is that the blue is the cumulative spend. So this is the 20% of the money that we pumped into treatment over 2 years. Okay, 20% treatment 2 years, roughly $20 million. Okay, so 20 million bucks. The red lines are how much each month is spent. The blue lines are cumulative over time, and you just kind of see that nice swing. And then the second year grant, you see the swing. This tapering off is because, well, we spent it all fast. 2 months or so ahead of schedule, right? So $20 million. How many people do you think that provided treatment for? Dee, don't tell. How many people? 10,000 people. Okay, we estimate 445,000 people in North Carolina have an opioid or heroin use disorder. 445,000. Half of the people showing up in the ED are uninsured. Okay, rough envelope math, 250,000 people without insurance. This money goes to those people. We've used 20 million to serve 10. We are Shawshank Redemption style, digging ourselves out of jail with that little hammer. And it won't change until we change the number of people that were uninsured, and that won't change until we change the way that we think about how we serve folks, how our system works. So good news, it's getting out there fast. You guys are helping that be possible, providing care at every turn. Bad news, it's going really fast. This shows that 10,000 person number. You can see this cumulative dot. I don't go to this slide next for those of you that have binoculars, and you could read that. It ruins my quiz. But this just shows the number of people that are being inducted and provided care each month. Now, okay, bigger picture on the money scene. So we know we got that next round of funding called STR, which is great, 23 million bucks a year. You add all that up, divide by the number of years, it's roughly $19 million a year. Bad news with that kind of money is that, what Ace Hardware is going to open up if I tell them, we've got money for nails now, but this town will have no money for nails in 4 years. What provider is going to open and scale, right? So this money, while it's a good injection of cash into treatment, it really struggles to sustain care over time because it's not a sustainable business practice for a lot of providers. I know a lot of providers are taking risk to expand their services in various communities. We're really appreciative of that. We're trying to do everything that we can to help make that possible as well. And so this is kind of drives home that point. The Assistant Secretary talked about the most recent round of funding. So this is a little bit early news that you've probably seen from SAMHSA. We'll be pushing out something soon here in the state, but the most recent STR grant, this is that grant that the Congress renewed. They folded those funds into SOR. Oh my God, it gets horrible. Into the other grant, and the great news about that, again, hack, wonk, that thing, is that it allows us to be really flexible and creative, and it also means that DD doesn't have to fill out another really long application, and a little bit, there'll be a mildly long thing, I'm sure, but we have to, kind of work together through that. But either way, that's $12 million. So we have another $12 million coming. We expect, more. I may have just pushed for that. So we hope that we'll continue to get those resources while we attend to, remember, Shawshank ourselves. Okay. Am I done? I think, no. Uh-oh. I feel like there was one more slide, but I'm not getting anything. Reverse? No. I'm frozen. Help. Hi, does anybody know how to advance the schedule? Okay. Oh, there we go. Excellent. Okay. Woo. Okay, now it's going to start to go crazy probably. Okay. SuD Waiver. So I talked about how we're changing our Medicaid system, right? A big part of that was getting a recently approved 1115 waiver and how we can provide more innovative services outside of the normal fee-for-service system. So a big part of that was also applying for an SuD waiver. That's that thing that she was talking about earlier with regard to like IMD exclusion for SuD, and then really building out the levels of care throughout our Medicaid system. Our Medicaid state plan has classically been very stingy, right, and paid for very narrow groups or populations, very narrow services. And the team's like, let's use this window to do this right and really rethink the way that those Medicaid services work. So in size 10 font for your easy reading, I have provided the overall schedule of what we hope. It'll slip, it'll move, it may be faster, but our kind of current vision. We're working on getting our final implementation plan from CMS. And so we hope that that will be done soon. But what you'll essentially see, big picture, is rolling out at every ASAM level of care service definitions that provide Medicaid coverage for those folks. So it will transform the way the Medicaid system currently can support those with SuD, both in the community and in the IMD. So we're very excited about this. This is great. And this, frankly, fits into our broader strategy overall of trying to make sure that everything we're doing is evidence-based. Right? We cannot screw around with what people hope and think, right? We have got to do what works. And clearly I have cover to say that. And so we are going to continue pushing in that direction. Change is hard. If it's hard, blame Sarah. She's going to help you. No, I'm kidding. We're going to work together to try to figure out how to reclass this and to share this message, and this is going to be a big part of this. So you'll continue to see this roll out between now and 2020, and then licensure in 2022, et cetera. But really, September 2020 is kind of the end date for a lot of stuff. But we're trying to bring up critical service levels very soon. Okay, let's see. Next slide. Oh, there we go. Okay, so the big thing, right? That whole transformation around our waiver and the way that piece works, that changes things in a really good way for everybody that has coverage, right? We hope that those levels of care are a model to our private payer partners as well, to really provide parity in this space, to make sure that they're providing those levels of care as well without authorization, et cetera, et cetera, et cetera. But it doesn't change a thing for anybody without insurance, right? Builds capacity in community, maybe there's some spillover effects with some uninsured funds, et cetera, but there's never actually going to be a change unless we do this. We have 500,000 people that we think Medicaid expansion would change their lives. It's free $4 billion. You know, every time I talk to my counterparts in California, they're like, thank you so much. I'm like, why? Like, for sending all those North Carolina taxpayer dollars to us, because we're not getting them back, right? So I hope you'll be talking about this, using your expertise and your experience, talking about it with people in your community, talking about it with your county commissioners. You can talk about it in other states too, but I'm primarily thinking about North Carolina. And because it is obviously a big game changer in how we could provide services. And if we got our uninsured population down to 500,000 at its current resource levels, we'd actually be able to really stop. We're spending just enough money in our safety net system to keep people in crisis, right? We're spending just enough money so that they're not dying, but they're staying in crisis, right? And so how do we finally, if we could double the amount of resources we're spending per person with expansion and really reinvest in the system, we could finally be in a place where we're spending enough money to actually get people towards prevention, care, community-based sustainability. So this is really a game changer for a lot of reasons, but we're still marching forward no matter what. Okay, that is the end. See, it wasn't that bad. Thank you all so much. It's a pleasure to be here, and I hope that you will tweet at me and email me and let me know if I can help in any way. Thank you.